very warm good morning to the respected faculty members, my seniors and juniors. Today I'll be starting my presentation with anyone, anything and anytime. So when I first joined here in emergency medicine, Akshay sir had taken an introduction class and he had beautifully described emergency medicine in just one sentence. That is anyone, like whether it is an adult, a pediatric or a geriatric age group, and anything, whether it is a medicine topic or a surgery or a urological case, and anytime, whether it's morning, night, or a Sunday. So emergency physician is available all the day. This topic, I've chosen this as my introduction slide because today we'll be discussing two topics. One is by Dr. Sanit, which is on acute heart failure, which is a pure medicine topic. On the same day, on the same discussion class, we'll be discussing an entirely different topic, which is a pediatric urological topic. So we'll be discussing about a young boy who presents with an abdominal pain and a pain in. Starting my topic, pediatric urological emergencies. Myself, Dr. Sridevi Aravindan, junior resident in Department of Emergency Medicine, and my moderator for today's presentation is Meera. So we'll be going through. First, we'll be starting with the introduction, torsion testis, phimosis and paraphimosis, priapism, tourniquet syndrome of penis, zipper injury, and all these procedures will involve a lot of painful procedures. So we'll be ending our discussion with a discussion of nerve blocks. So why is it important? So pediatric urology. So we'll be dealing with the genitourinary structures of a child, which if destroyed will cause infertility and ejaculatory failures. And always we know that the functions of maturation and the everything about that. So if the urethra and the urogenital structures are destroyed, then the patient will have a difficulty in urination, and sometimes it will also lead to a child having a suprapubic epithelialization or so many urological surgeries being done in a very young age. So which will affect the quality of life of the patient. Can someone read out the question for me? Dr. Sheena. How will you triage this question? The primary survey is normal. Right. Thank you. So now we'll be discussing about acute scrotum. So the causes of acute scrotum, we can classify it under 4 headings. First will be torsion of testis. Next, infections, which may include epidermidis and orchitis, and trauma or tumor. So tumor is basically painless. Only when there is a hemorrhagic transformation, there will be pain in the tumor. And vasculitis. Like some children with vasculitis, like autoimmune vasculitis, Kawasaki disease, etc., may present with the acute scrotum. So our duty as an emergency physician will be to identify torsion among all the 4 causes. Why? Because as we know, the torsion testis. What happens in a torsion testis? That is twisting of the spermatic cord. So when along with the testis. So when the spermatic cord gets twisted, so inside the spermatic cord we have the testicular artery. So the testicular artery will also get twisted. So the blood supply to the testis is cut off, and the testis will undergo ischemia and necrosis. So to prevent that, you have to act very fast, because from the time of onset of pain, if you intervene within 6 hours, the salvageable rate of the testis is 96%. But if you delay your procedure by 12 hours, it is only 20%. And after 24 hours, if you intervene, the salvageable rate of the testis is only 10%. So who are at risk for developing a torsion testis? There are 2 groups of individuals who are at risk. Those who are having a well-clapper deformity of the testis and an undescended testis. So what do you mean by a bell clapper deformity? Dr. Gibran, can you please tell me? Very good. Thank you so much. So, I'll be describing out what is a bell clapper deformity. So, this is a bell and this is the clapper of the bell. So, it will be moving horizontally. So, what happens in a bell clapper testis? The normal lie of the testis is vertically inclined. So, in a bell clapper deformity, the testis is horizontally inclined. So, it will have a similar motion to this bell clapper. So, and also one more thing that you have to know is the process attachment of the processus vaginalis. So, this is the processus vaginalis which is covering the testis. So, in a normal testis, it will be adherent to the testis. So, it will not allow for a lot of movement in the testis. But in a bell clapper deformity, it is loosely attached. The attachment of the processus vaginalis is not proper, which will also increase the mobility of the testis. And as we all know, testis is an intrauterine organ, intra-abdominal organ in the uh, intrauterine life. So, and it will descend by the end of the 9th month of intrauterine life. So, if there is any undescended testis, so as we all can imagine, the process vaginalis attachment will not be proper, and there are chances that the testis will undergo torsion in such cases. But only difference is that the testis will not be there in the scrotum. So it will be around somewhere here. So the patient may present with the complaints of abdominal pain, not an acute scrotal pain. So in case of abdominal pain also, you have to identify, first you have to examine whether there is any missing testis in the scrotum. And if there is any missing testis, you have to think about undescended testis and the torsion of the undescended testis also. And one more anatomical point I want to tell you is regarding the cremasteric muscle. The cremasteric muscle supports the testis in the scrotum. So the function of the cremasteric muscle is to first the protection of the testis, and one function is like regulating the temperature at which the testis is. So we know that the testis is kept outside the body for a little lower temperature for spermatogenesis. So when the body temperature is so high, the cremasteric muscle will contract and pull the testis a little upward. And when the temperature is low, the body temperature is low, the cremasteric muscle will relax and like so that the testis is little away from the body. So what happens is when there is the contraction of the cremasteric muscle, along with the bell clapper deformity. So there is a bell clapper deformity and the testis is like unstable. Along with that, if the cremasteric muscle contracts from below, there are chances that it will undergo torsion. So this is the basic pathophysiology of torsion. And one more anatomical point is left testis lies lower because the length of the left spermatic cord is more. So the left testis lies lower, and because of that, the length is also more. There are more chances that the left testis will undergo torsion than the right. And is trauma a risk factor for testicular torsion? What do you think is trauma a risk factor for testicular torsion? Yes, it is a risk factor because, as I said you told you, because when there is trauma, there is a vigorous contraction of the cremasteric muscle. And if the patient is having any bell clapper deformity, even otherwise also, there are increased chances that the testis can undergo torsion. But when there is a trauma to the scrotal region, so what you have to understand is you should examine the patient for any pain and tenderness. You have to rule out torsion, and also sometimes what happens is in the spermatic cord you have the testicular artery. So due to trauma, there may be a hematoma which is developing the testicular artery that may press on the testicular artery and decrease the blood supply to the testis. So the blood supply to the testis trauma may be compromised due to two reasons. One may be a torsion testis, one may be some hematoma which is developing and which is decreasing the supply to the testis. So you have to rule out these two, and then only if that is okay, then you can send the patient. And coming to the incidence by age of testicular torsion, you can see that it's a bimodal age distribution. So first will be the infant age group, especially in the neonatal age group, and the next second peak will be in the adolescent age group. The second peak will be in the adolescent age group. So how will you know that there is a testicular torsion in an infant? Because the infant will not be complaining of an acute scrotal pain. table comes internally, the heading, as you can read, is condition associated with inconsolable crying, irritability, and lethargy in a neonate. So any child presenting with an inconsolable crying, irritability, or lethargy, you have to examine all the organs. And along with that, you have to examine the genitourinary also. Abdominal examination is always complete after you examine the genitourinary structures, and you should always examine for a torsion distance, any genital hair tonicus, and paraphimosis. This is how you diagnose an infant. An adolescent will complain of these symptoms. First, there will be, of course, testicular pain, which is sudden in onset. And also, nausea and vomiting will be there. Because the testis is an intra-abdominal structure in the intrauterine life. So, there are some nerve supply which arise from the cilia ganglion also. So, when there is a torsion of the testis, the cilia ganglion, there is a stretch of the cilia ganglion, which cause nausea and vomiting. And there will be swelling of the scrotum. Fever may be an occasional finding, and painful urination, and there will be abdominal pain and back pain because of the nerve supply. So once you find that the patient is having an acute scrotum, then you have to go for examination. So during examination, first you have to need to do the inspection and see for any testicular swelling, that's unilateral testicular swelling, and then you go for palpation. So the normal consistency of the testis when you palpate is firm in consistency. But when there is torsion, the consistency will change to hard. And also tenderness will be there, and the testis will be highlighted. Because as I told you, there is twisting of the spermatic cord. So the twisted spermatic cord will pull the testis upward. So there will be a high riding testis. And next, you have to examine the cremasteric reflex. Can anyone tell me how to do the cremasteric reflex? Dr. Srishti? Yes, it's a superficial reflex. Thank you. Very good. Thank you. So it is a superficial reflex. So what you do is with the end of the knee hammer, you stroke in the downward direction, and you have to note for the contraction of the cremasteric muscle. So when there is a contraction of the cremasteric muscle, the ipsilateral testis will be pulled up. So the cremasteric reflex we are noting because the nerve supply of testis is also L1 and L2, and the cremasteric reflex is the testicular L1 L2 nerve root. So when there is a torsion testis, there are chances that the cremasteric reflex will be absent. But it is not always, because when there is a torsion testis, the patient will be in so much pain, and sometimes you will not be able to elicit this test properly. Uh, yes, sir. Yes, sir. When the patient presents initially itself, we have to test it. I'm telling about the twist score, so it will come in. There is a scoring in it. Okay, sir. As soon as the patient comes, that we have to evaluate the patient for torsion testis, and while doing the examination, you have to test for the cremasteric reflex. So now we discussed about the torsion testis, and one important differential will be infection, epidermis. So how to differentiate it from a torsion testis? So this is an infectious process. So the pain will not be a sudden onset pain. It will be a gradual onset pain with the severity peaking over the days. And fever and dysuria is more common with an infection, and vomiting is less. And there is no twisted spermatic cord to pull up the testis. So the position of the testis will be normal, and the cremasteric reflex will be present. But even though you have all these, if there is a doubt, you have to always go for the color Doppler and confirm. Because as I told you, torsion testis is an emergency. If you delay, there will be ischemia and necrosis of the testis. So always go for the color Doppler for diagnosis. And also one more test that you need to do is presence. That is, you can, while doing examination, you have to elevate this process. So if the pain is reduced, then it is an infectious process, epidermolysis. If the pain is increased, then it is a torsion testis. So So how will you how will you write your interpretation? You have to write it as positive or negative. So you can remember it like this. When you elevate the testis, when the pain is less, so it is actually positive for the patient. So you can write it as positive. When the pain is increased, it is negative for the patient and negative. Yes. Problem is there, sir, but it is like how to do the interpretation.
Positive also a problem, negative also problem. So negative is a larger problem than positive. That's what I think.
So now that one patient comes with a torsion testis and acute scrotum, so you have examined the patient. So now you have to put the twist score. Twist score stands for testicular workup for ischemia and torsion. So there are 5 points, with 2 points each for testicular swelling and a hard testis and palpation, and 1 point each for nausea, vomiting, high riding testis, and absent rheumatic reflex. So once you do that, the total score will be 7. So this is the algorithm that you have to use. So when there is an acute scrotum, you put the twist score. So when the twist score is 0, that is a low risk patient. You don't need to evaluate further for a testicular torsion. No investigation necessary. When there is a twist score of 1 to 5, then you have to send the patient immediately for a testicular ultrasound. But when there is a yes, yeah, yes. And when the twist score is more than or equal to 6, so it is like suggestive of torsion testis. So you don't have to investigate further for a torsion of testis. Like you don't have to go for an ultrasound alert. You can directly take the patient for OR. Only there is one thing that you have to know. Then you have to put the Tanner staging also. Like when the twist score is more than or equal to 6, then you put the Tanner staging. Tanner's 1 to 2 is this is the Tanner staging. So it is based on the appearance of pubic hair. So when there is no pubic hair or straight hair that appear in the penis, very less pubic hair, that is Tanner staging 1 and 2. All others are more than 2. So when the Tanner staging is 1 or 2, that is a relatively younger child, then you have to go for a scrotal ultrasound for confirmation. If the Tanner staging is more than equal to 2, the 3 to 5, then you don't need to go for an ultrasound. You can directly proceed for a urological consultation or proceed to an OR. So this is about. Yes, sir. That is because the score, it is mainly because when they did the this Swiss score validation, so they have validated in 3 to 5 age group mainly. So validation for 1 to 2 age group was not done. So that is why it is told that you have to further investigate. But 3 to 5, the sensitivity and specificity was very high, more than 95%. Yes, sir. Both sides. Swiss score and with the anesthetic. Yes, sir. Yes, twist and yes, sir. Yes, sir. Yes, sir. Not sure, sir, because validation is not. So now that like after putting the tunnels twist score, so when there is no low risk, nothing to be done. So when there is an intermediate risk or high risk, then you have to go for the testicular ultrasound. The testicular ultrasound for detection, the sensitivity and specificity is very high. Sensitivity of 80 to 98%, specificity of 97 to 100%. So should we wait for the radiologist to come and do the ultrasound, or can we do the testicular ultrasound? What do you? Okay. So once. Yes.
We
Uh,
all know with Michael Bailey. Yes. To read the details of point of care, read all the many focus. One of the leader, AI will have medical institute or
study was done in this patient, 36 patient, and the ultrasound was done by an emergency physician. And the sensitivity and specificity for detection of torsion of testis was found out to be 95% and 94% respectively. So we can actually go on and do the testicular ultrasound. So how to do it? First, of course, you have to give adequate analgesia because you have to actually check for the color Doppler flow. So when you tilt your hand or if the patient is agitated, then you will not be able to do the test. And you have to properly explain the patient and try not to use a cold gel because it will again create stimulation of the scrotum and the cremasteric fluid. And you have to use the high frequency linear probe because you're scanning the superficial part. And you have to select the preset as small part or in some ultrasound machine testis preset is also available. So first you have to scan from lateral to medial and then up and down, and also in one view you have to put your probe in the middle. This is the this one test. This is one hemiscrotum, second hemiscrotum, and the median bracket. So you have to put the ultrasound probe in the middle and scan both the testes simultaneously. So this is that view. So you can see both the testes with the median bracket. So the normal echo texture of the testis and the ultrasound is similar to that of liver. So this is the normal testis. And when you examine this hemiscrotum, so this is the testis, and you can see the head of the epidermis. And when you scan properly, you get a structure like this. Don't think that this is a pathology. It is a normal structure. So there is a this is the normal structure. So there is invagination of the tunica albuginea. It is called as mediastinum testis. So this will appear in the ultrasound as 5 layers. And now to test for torsion, what we do is scan both the testes simultaneously and put the color Doppler. So in the testis which has a normal flow, you will be able to see some flow in the color Doppler. Whereas in this testis, you can see there is no flow. That means there is no blood flow. There is a torsion in the testis. And how to differentiate it from an infection? Here you can see that there is so much vascularity. So in infection, as we know, the vascularity increases. So you will be able to see increased vascularity. And this is the testis and this is the epidermis. So there is increased vascularity in the epidermis. So you can know that this is a infectious process epidermis. So you can diagnose testicular torsion and infection with the ultrasound. So now you can see in when you compare both these testes, there is increased vascularity here. There is normal vascularity here. So this testis is having an infection. So now that you have done the ultrasound also, if you are sure, so that is where the ultrasound by the ultrasound done by emergency patient comes in floor, because we are there on the floor, we are seeing the patient and we find that there is a testicular torsion, we can do the ultrasound. And if you find that the flow is decreased, then what you can do is you can go for a manual detorsion. So how to do a manual detorsion? So we have we know that there is something called as open book procedure that we have heard. So it is not always an open book procedure. Sometimes it is a closed book also. So I'll explain you why that is. It was told as open book because mostly the testis will the torsion will be happening from lateral to medial. So how you have to relieve the torsion? You have to rotate the testis from medial to lateral. That is like opening and closing. This is in 2/3 of the patient, but in 1/3 of the patient, it is just the opposite. The testis will be in the torsion will be from lateral to medial, so you have to go for medial to lateral. So don't get confused. So in 2/3 of the patient, it will be twisted inward. So you have to de-rotate it outward. So that is the open book. But in 1/3 of the patient, you have to do a closed book. You have to do the opposite thing. So how will you know that whether you should do an open book or you should do in the opposite direction? So that is basically you cannot know with the physical examination or with the ultrasound. You have to do a trial and error method. Catch hold of the testis and think that the patient is belonging to the major 2/3 and try to rotate it in the open book fashion. So if the patient is having so much pain, the pain is increasing, or if the you are feeling a resistance, then try to do it in the opposite direction. So if you're able to do in the opposite direction easily and there is relief of pain, that means that, so that is confirmed that on which side the torsion is there. Are you okay with this one? So that's how you have to do the detorsion. So it has to be done once or twice. So how do you know whether you have to twist this 1, 2, or 3 times? So that is given. So you have the endpoint. When what is the endpoint of manual detorsion? First is relief of pain, and next is return of intravesical blood flow. So this is where the ultrasound again comes, because when you try to do a manual detorsion without giving adequate analgesia for the patient will not allow you to do this trial and error and all. So better is to give adequate analgesia for the patient and confirm your detorsion with the testicular ultrasound. So that is why testicular ultrasound is very important. And even after, if you are very successful, the success rate of manual detorsion is between 30 to 70%, as high as 70 and as low as 30. So it's very unpredictable. Yes. After the manual detorsion also, don't think that everything is like okay. You have to call the pediatric surgery and go for, they will come and do the surgical exploration of the patient. Because so the value of the emergency physician comes here. So when they do a surgical repair, so if we are able to achieve the vascularity, if we have promptly diagnosed the testicular torsion and achieve the vascularity, they will have to do just a fixation of the testis, orthidopexy. But if we did not identify the torsion immediately, or the patient presents late, manual detorsion was not done, and the patient the ischemia has already developed or is a necrosis, then they'll have to take the testis out. They'll have to do the orthidectomy. So that's where like we can be important. Ischemia sign, yes, uh, 6 hours. First is like 96% salvage will take within 6 hours. If it's like 12 hours, it is 20%, and more than 12, 10 hours, 12, more than 24 hours, it is like 10%. That is about the testicular torsion. And coming to torsion of the testicular appendage. So this is the testicle, and you have the testicular appendage here, and epididymis also will have the appendage. So these structures may undergo torsion. So how, how is this important is, if this is not an emergency, it is only conservative management that you have to do. It's just that you have to differentiate between the testicular torsion and the appendage torsion. The clinical findings will be the pain will not be as severe as in the torsion, and also when you examine, the tenderness will be less, and there will not be a high riding testis. And the examination finding that you can see, you can see a blue dot ischemic appendage. If the total wall is thin, you can appreciate the ischemic appendage. The blue dot sign will be there. So the treatment is conservative only. You have to give a good scrotal support and ask the patient to wear a tight fitting garment, and limitation of activity for 1 or 2 weeks. And you have for pain, you can give oral analgesics, and you have to also tell the patient that there is a peak of the pain, and then it will go. So when the patient comes in the initial days, then after you give the treatment also, after he goes home, the pain may peak for 1 or 2 days and then come down. So if he has any doubt, ask the patient to come back again, and you have to just note this point. The pain may worsen before ultimate improvement. And then so now coming to the differentiate. So when there is a infection, so we have discussed how to differentiate that. And also in the management, first you have to send for urine analysis also. There may be a pyorrhea and bacteria. And before starting the antibiotics, send a urine culture and sensitivity. So mostly the organism is chlamydia and Neisseria gonorrhoeae, and you have to start the antibiotics. So by starting the antibiotics, what you have to know is there is outpatient management and inpatient management. When the patient is able to tolerate orally, the patient is not having any systemic features, then you can go for an outpatient management. In outpatient management, you have to see whether the patient is sexually active or non-sexually active. So in the non-sexually active group, you can give trimethoprim, sulfametrazole, or cefalexin. And in the sexually active age group, you can give an IM dose of 250 milligrams ceftriaxone plus, and then you can discharge on oral antibiotics, doxycycline, erythromycin for 10 days. And if the patient is having systemic features and not able to tolerate orally, then you can do an inpatient management with ampicillin and gentamicin or gentamicin. That was about the acute symptoms. So just the differentials of scrotal swelling in a child without with a painless scrotal swelling in a child. So you have to know this need to differentiate it from the other serious causes. So there may be an acute idiopathic scrotal edema, hydrocele, inguinal hernia, varicocele, spermatocele, and testicular stoma. There is nothing in emergency that you have to do for these disorders, but you have to just understand what is it. So in the hydrocele, so I will not be going in detail. So in the hydrocele, when you do the testicular, there will be a swelling which will not be painful, and there will be no tenderness. And when you do the ultrasound, you'll be able to see the hypoechoic structure, hypoechoic fluid. So in the emergency, what you have to rule out is rule out that there is no biopsy, there is no infection in the fluid. So examine and look for any signs of infection. And when you do the ultrasound, look for any hypoechoic structures in the fluid. And in the varicocele also there is just similar to the varicose appear in the leg. So there is a varicocele in the papilliform plexus of legs. So why emergency is only when there is a trauma to the varicocele and it starts bleeding currently. Otherwise, if the patient is asymptomatic and he has just come for this varicocele, that is not an emergency. Just rule out torsion or any bleeding, and then you can safely discharge the patient for a pediatric surgery program. So that was about the testicular emergencies. If you have any doubt, you can ask me. Otherwise, we'll move on to the next one. Can you read out this for me, Dr. Golak? So this is a patient with a constipation and acute retention of urine. So how will you approach this patient? Uh, the patient is also having a so the patient is having a constipation and urinary retention for urinary retention. So first, you should always not think about urological emergencies first. Even if it is an acute retention of urine, there is constipation. So the patient is not